help us to put the most appropriate response in accordance to those demands. For instance, this particular environmental demand at the moment will be that you engage with the material and understand it. And if you do that, and there would be more learning, and that could be called as adaptive in nature. But maladaptive, or in other words, abnormal behavior, may be due to either mental illness, or it could be in relation to a maladjustment as well. The maladaptive behavior, we're always talking about a range of behavior. It could relate to fear on one end, chronic fear on one end, to severe reality distortions on the other. So if we have feelings of intense fear or anxiety, which most of us go through, this could be also called maladaptive behavior. And on the other hand, if a person has severe reality distortions in which the person doesn't know who he is, or doesn't know where he comes from, or thinks that he's in another place altogether, this could also be a severe reality distortion. This is also part of maladaptive behavior. But generally, maladaptive behavior is indicative of having a coping ability which is lesser than what is required in order to deal with a particular demand. So these reality distortions can affect your and my ability to engage with the environment, and it can also have negative consequences on our everyday life. I'm looking at one case of a person who I will call Ratan, and he's working in a corporate, and here there are very few cases that have been reported. He is being provided gloves and masks during the work hours. However, he's quite worried about infection. So he takes safety precautions, and when he goes home, he avoids going too close to his aged parents and his young children. So though he's worried about the spike in cases, he's not continually dwelling on that worry, but he goes on to do other work and go on to his regular routine. So he has feelings of fear and anxiety, but he's able to manage them and continue on with daily functioning. So you could say he's a normal functioning adult, or there has been no major impact in his life. Whereas if you look at a person whom I call Abhay over here in this case, though he's been giving protection equipment and he's working in a corporate as well, he's very, very worried and anxious about getting infected. So even though he's been given protective equipment, he tends to feel that it is not enough, and he panics, he becomes angry for small reasons, he experiences sleep disturbances, he tries to avoid work, and then he can't continue with work because of his feelings of anxiety. So there could be a possible adjustment disorder in this case, and he may need psychological help as well as a brief course in anti-anxiety drugs. So this person you could call as anxious, and is a form of maladaptive behavior. But again, if you look at this another case of a depressed mother, lady whom I call Sushana in this particular case, she's a domestic helper. Her husband during the COVID lost his job. She has 2 children. She cannot repay her debts, and gradually over a period of time she becomes very slow and withdrawn in her work and in her relationships with others. So she's unable to care for people, and she feels quite tired very often. And then she starts having thoughts in which she feels very hopeless. The future looks very bleak, and she often thinks of dying, but she's just continuing for the sake of her kids. Now, you can look at these symptoms and say that they are much more severe as compared to the other cases. So it could be possible depression, and which has been precipitated by the COVID-19 stress, and it requires some help in solving problems in her day-to-day life, and she may also need medication if the suicidal thoughts persist. So you can see maladaptive behavior mostly in case 2 and case 3, but you also see that there is a difference in severity of the symptoms. So I'll go on to the next section, which talks about common psychological presentations. But before I do that, what we need to understand here is maladaptive behavior can be quite common to even normal people. We are all mostly normal people going through some very extraordinary times. And because of that, our coping resources can be severely challenged. So now going on to some of the common psychological presentations that you can see during the pandemic. The important thing you can think of here is that many of these symptoms that you will see have also been seen in disasters, particularly if there have been floods, if there is a tsunami, if there have been other chemical hazards the person has been exposed to. All of these symptoms can be seen even in the present pandemic, because it's more of a biological disaster. And you will see that many people recover spontaneously from them with some brief psychological inputs, and some may require much more sustained help as compared to others. There could be an overlap of problems, particularly if the person has already been having depression or is under the influence of alcohol. Problems could overlap with one another also, and we need to try and remember that we are all trying to cope with something which is extraordinary and unprecedented. Some of the common fears that one could have here is the fear of contracting the illness. So this is a very strong and dominant fear among all the others, and this could lead to misinterpretation of symptoms. For instance, you have a small cough and you think that, this could be flu related, but you immediately think that it could be related to corona. This is quite common, and many people try to get tested just for reassurance sake. You will find several elderly people also who will try to check their vital statistics again and again just to see that they are normal. So this need for reassurance also stems from the fear of contracting an illness. Some people may hoard medicines or supplies, or some people may have several doubts in relation to whether the masks that they are wearing are good enough or not. Okay, and some of the fears and the worries could be related to the reality, like loss of job or inability to make certain payments. And on the other hand, you can see in some people there is also an uncaring attitude. It's a feeling of, nothing is going to happen to me, so I don't even have to wear a mask. So you can see this in young people many times. So the other negative feelings and common fears that you can see is also the fear of falling ill, the fear of dying. I mean, we all have the fear of dying, but in this particular time during COVID-19, it has become more of a pertinent area in which everyone is trying to grapple with. Avoiding health facilities or any crowded places because of the fear of COVID. Then you also feel a powerlessness to protect people whom you love. So many times if somebody has been infected in the family, there's a feeling of helplessness that I can't do anything in order to make that person feel better because you're probably not in contact with the person at all, and there's nothing you can do. So there's a loss of control, and that is also a very uncomfortable and disturbing feeling. There could be a separation from loved ones, particularly if the person needs you. For instance, there have been so many cases in which parents and children have been separated, and there could be a lot of feelings of guilt and pain and anger and helplessness when it comes to those situations. Then there could be fear of caring for elderly people with the idea that they have the illness, or sometimes people with disabilities also. Then feelings of boredom, loneliness, depression, all of this can come to the forefront, especially when you're being isolated. In daily life, most of us have been in social distancing and lockdown-related situations. So here you find that your whole day's routines have been changed. There are so many new things which appear in our day-to-day lives which we have never encountered before. For instance, many males have started doing chores at home which they have not been engaged in doing before. Or it could be mothers taking on the role of a teacher for their children. Work from home has its own challenges, and it may be difficult to separate sometimes household and professional activities. Also, there have been times in which there is couples who are living together for long periods of time. They are not used to doing this because they are used to working and meeting once a day. But now they have to spend the whole day together. Or there have been long separations in which family members are living in other places and have not seen each other for months. There's financial stress and interpersonal strain as well. So the reactions to all of these can be, it can be boredom, it could be very moodiness, or it could be a lot of irritation and frustration also. And in this context, many people have resorted to taking substances which can help them to cope with the stress. So overall, a sense of uncertainty and the loss of control can be seen. Now, if you look at the phases in which many of these mental issues have become prominent, this particular slide is talking about acute and long-term phase. In the acute phase, and you can say that we have passed this stage already. This is during the outbreak of the coronavirus, and you can think of it between 2 to 6 months. So during this time, we could see more of experience of fear, denial, anxiety, insomnia and dissociative symptoms, symptoms of depression, perhaps suicidal areas, substance withdrawal, and even relapse of certain mental health problems. And in the papers, we could see daily articles in which they were talking about how much stress people in the front line were actually going through. Okay, so in the long term, you can find that that is in the current situation that we are in now. You can find that a lot of people are going through grief. Something called survivor's guilt. I'm not sure if everybody is familiar, but survivor's guilt is when a person, perhaps in a family, is surviving and others have passed away due to the coronavirus. So the person who is alive ends up feeling, why was I alive? Or why am I continuing to survive, and why others have passed away? So depression, substance use, even relapses of previous illnesses, and you could also see symptoms of PTSD as well as somatization. Okay. If you look at this context and think of who is most vulnerable, it is the same as that in disasters. The most vulnerable will be the children. It will be people who are elderly, pregnant women, people with disabilities, particularly those who are homeless, who are living in marginalized communities. And in this lockdown, there are places which are very overcrowded, where supplies are very less, and these communities are more vulnerable, not only because of the infection, but because of the context in which they are living in. people who are having chronic medical conditions like cancer or asthma, or people on dialysis and who need to visit health facilities very often, these are also very vulnerable, and also those who have a history of severe mental illness. Okay. So what we hear also about quarantine centers, and we know that there are people who are living in those centers. The government has put up many centers in different places in all the states, and here you can see there's a lot of psychological distress among many families, primarily because of the fear of infection, of misinterpreting some minor physical symptoms. There could also be a lot of frustration because of loss of routine and because of lack of social contact with others and feelings of isolation. So there could also be a lot of stigma from the community, like a lot of people who come back from the quarantine centers and try to return to their normal routine. The neighbors and even colleagues, they may experience a lot of stigma from them because of the fear of infection. Finances and loss of work is also another prominent feature, even in quarantine settings, and lack of regular supplies. In hospital quarantine, you can see a lot of marks of psychological distress, particularly health-related anxieties. And this could range from very mild anxieties to very severe ones also. So this is not only in relation to their current status, but also if the virus load increases, or they may feel that they may get other types of infection while staying in the hospital premises. So health-related anxieties are very common and need to be addressed. Then there is also depression and anxiety, where they may have a fear of more severe illnesses, or they may keep thinking about how they got infected. Perhaps they went to a particular social setting where they think that they got the infection. So they keep remembering those particular situations again and again and feel more and more guilty for contracting the illness, and perhaps even feeling bad about all the inconvenience they are putting onto their family members. So depression and anxiety in this context is quite common. Then they may feel emotional exhaustion because they are running through these thoughts again and again in their mind, feeling the same negative emotions again and again, and getting more and more stress. They could have a feeling of numbness in which they blunt their emotions and concentrate on the rational aspects of their disease, because they are inside, they are emotionally tired of thinking of the same things again and again. They could be insomnia along with it. Substance withdrawal can happen because there are many people who are addicted to alcohol, smoking, and maybe chewable tobacco, and because of that is not as available, so there could be severe withdrawal symptoms. End of life crisis is also experienced, and acute stress reactions, PTSD, and even if they are not experiencing some of those symptoms at this particular time in the hospital quarantine, there could be times when they are released back to go back to their homes, and then they may experience some of those symptoms. So in addition to all of this, it's not only people experiencing the maladaptive aspects, but there are several people who may also report many positive feelings and positive experiences as a result of the quarantine. So looking at the third part of the presentation, now here there are mental illnesses that are related to COVID-19, and I think Dr. Ashish Goyal has spoken about some of these illnesses earlier on. But before I go on to this, can I ask if there are any questions or any thoughts which people want to share up to this point, and then we can go on. Is there anybody who would like to say or share any observation or thought at this point? And after that, I can continue. Is it okay? Shall I continue? Okay, I'm not able to hear anybody, so I think I'll just continue onward. Now, these are some of the common mental illnesses that can be seen during COVID-19. Many of these symptoms are quite well known to people. So, I'll go at the next slide. Depression, suicidality, generalized anxiety disorder, panic disorder, phobias, and OCD. Now, because of the amount of information that has been shared over the internet and in daily life, we have very much more information as before in relation to the symptoms of these particular mental illnesses. So, what we need to remember is that we can't say that because of COVID-19, there is the emergence of a severe mental illness. What we are saying is that many of the symptoms can be seen not only because of COVID-19, but also because there are many vulnerable individuals who have already been suffering such conditions earlier. So because of the present condition of COVID, there could be a relapse or the symptoms may worsen. But other than that, you can't say that it is a direct consequence of the COVID. Okay, so we know that there are several factors related to the onset of mental illness. It could be the genetic vulnerability that the person has already. There could be several features within the environment. There could be personality features. There could be lack of social support. And all of these factors, they engage with one another in a way which is very dynamic. And when that happens, all of these determine together whether the mental illness will start or not. So, looking at some of the common symptoms here, anxiety disorders are very many. There are around 10 or 12 anxiety disorders, and PTSD and phobias, all of them are included in those anxiety disorders. Now, some of the signs of anxiety are feeling of being overwhelmed by emotions or persistently worrying about something. The person knows that the worry is excessive and tries to control that worry, but is unable to do so. So, there is a lot of restlessness and irritability because of that, and you will find that people with anxiety signs are those who have had previous bouts of anxiety as well. So if today they are not worrying about COVID, tomorrow they will worry about something else. Perhaps it will be the future of their children, or it could be the relationship they have with somebody else, or their job. So you will find that the topic for anxiety may change, but they will continue to be persistently worried about several things. So they could have difficulty concentrating or have certain sleep problems as well. These are some of the common signs of anxiety. There could also be the signs of a panic attack. People who are experiencing this type of panic attack will feel as if they are going to die, and they are very fearful about a particular attack, whether it is going to happen in the open or whether they will not have any other help at that particular time. So they have very severe physiological symptoms of sweating and trembling, shortness of breath and pounding heart, and they feel that at any time the attack will happen. So because of those panic attacks, they will not go outside their homes, and they will choose to isolate themselves and fear panic attacks sometimes in particular situations also. So this can also be a form of maladaptive behavior. Then there could be signs of depression. These are very commonly known nowadays, that there is a lack of interest and pleasure in daily activities. There could be insomnia, there could be feelings of excessive guilt. The important indicator is here that we may all go through depression, whether mild or moderate or severe, but when there are thoughts of suicidality, which is continuing to recur, the suicidal ideation, and these things are meant to be addressed in a more professional way in order to deal with depression. Then there are risk factors for suicide, particularly if the person is trying to, is talking about dying or harming oneself. You will find many times there changes in the personality of that person or in the behavior of that person, and he or she believes that there is nothing more to life, and would like to end life and not engage in anything which is pleasurable. You can also see if the person has experienced a recent loss or there has been a crisis in the person's life, there are more chances that the person will go through a certain crisis like this. Going on from here, there is another aspect here called prolonged grief disorder. Now, as I was saying, all of us may have gone through certain losses, not necessarily the loss of a person, but it could be a loss of the daily routine that we have. It could be loss of a job or something else which you may have looked forward to but have not got. So many times when we engage with this type of losses, some people can go into what is called a prolonged grief disorder. There are many complicated forms of grief. We usually talk of grief where there are people who are dying or who have recently have had the death of a family member. But here, when we're talking about bereaved persons, it's a type of a complex disorder here, because the time for grief has been completed, but the person still continues to experience persistent grief. Many times these situations can come across because the person has not been able to say goodbye to the person who is dead. Now, you know that in hospitals nowadays you are not allowed to interact with the person who may be in the ICU, or at a certain point you may receive the ashes of a loved one but have not been able to actually say goodbye in a way which is healing. So this type of prolonged grief disorder can show up, and it may last up to 6 months or even more. It can interfere with the normal functioning. A person who has lost something else which is dear to him, may not be a life of somebody, can also experience this type of prolonged grief disorder. So here the person may feel persistent longing or sadness for the person who is deceased, may have a sense of disbelief or a sense of inability to accept the loss. So many times people who are not treated for this particular grief disorder can risk substance use. They may have sleep disorders and as well as impaired functioning. So prolonged grief disorder is something that is also being observed. Then there is psychological impact on certain specific groups. And here I'm going on to the fourth part of my presentation. So here we're looking at very specific groups and looking at the type of experiences that they may have and what you could term as maladaptive behavior. So first, in relation to children, children have experienced very different and unprecedented events in relation to COVID. Now, we are not only talking about children from a middle class background where they have adequate resources, but we're also talking about children who come from marginalized backgrounds, and the environment, the context from which they come from puts them at very different type of risk. But children nevertheless are very vulnerable both in relation to COVID, whether it is physical or psychological. So here you can see that children will tend to experience anxiety and fear and worry. They can also experience depression, difficulty in sleeping, and loss of appetite. Because of, again, a disruption of their daily routine, there is no contact with other peers. The routine that they are used to has been disrupted. One of our students teaches a group of autistic children, and she was talking about how difficult it is for autistic children to now engage in online classes and to get into a routine of having school mostly online. So quarantine and isolation also puts very different pressures on children. You can find symptoms of acute stress disorder and PTSD, as well as grief in many children. Many of them have been separated from parents and kept in isolation for long periods of time. Even if it is not, if they have not been infected or family members have not been infected, there are some who have to endure long periods of isolation at home. There was a case recently in which a child was had to spend a lot of time alone in the house with a domestic help, and the mother was in another country and was finding it difficult to return home. So these type of situations may produce symptoms of acute stress disorder as well as PTSD in some of the children. And you can see that children with physical and mental disabilities will have more trouble or more problems or have much more vulnerability as compared to others. At times there have been economic hardships, perhaps because there's a loss of job and there is a loss in the family, or there is grief in the family because of a loss of a loved one, and all these situations have a very deep and deep impact on the lives of the children. You can see in other cases a lot of neglect and abuse as well, because parents are unable to manage their levels of stress. Many times they neglect the child, or there could be different cases in which there is physical as well as sexual abuse. We have found that in Childline or any other of those organizations related to children have reported that there are higher number of calls related to child abuse during the time of COVID. Then we come to adolescents. Now, among adolescents, because of the particular development phase that we are going through, you can find that several adolescents who are in this particular COVID times may end up being very preoccupied with themselves. Usually adolescents are engaged in an identity crisis, so this may sometimes turn inside, and you may find that they're excessively preoccupied with themselves and their own behavior. They may feel a sense of insecurity, and there is more vulnerability to risk-taking behaviors, whether it is a substance or whether it is engaging in a behavioral addiction. Some of them, of course, may feel very invincible, as if nothing is going to happen to them. So you will find that many adolescents would go in for not wearing masks in public places, or they would engage in behavior which is questionable also, like driving very fast in certain places, or disregarding rules and regulations. Some of them, of course, may feel very afraid of leaving their homes, and many of them may face boredom and loneliness, sadness, aggression, and even irritability towards their siblings and other family members, because they will find it difficult to have outlets in which to share or do something which is meaningful. So you can also find there could be tobacco and alcohol addictions, and now which is increasingly common is behavioral addictions, and those related to spending more and more time on screen and on the internet. Many adolescents and young adults are in problems because of the stress related to exams. The uncertain future is something which they are unable to handle. So here again, high levels of anxiety and stress can be seen among them because of these particular unique features. The other aspect is in relation to couples. Now, couples in COVID-19, balancing the intimacy as well as the distance. There has been a lot of studies in relation to how couples are managing relationships in COVID times. And those who have studied family systems theory, there is a person called Bowen, and there are several others also. They talk about couples being on a continuum of engagement. On one side, there is what they call enmeshment, in which there is a very intense or close relationship in which there are no spaces, but there is a lot of togetherness, and on the other hand, there is a high level of disengagement. So many couples come on this continuum in different places. They may be either very engaged or as well as disengaged or somewhere in between. So in these COVID times, there have been intense periods of togetherness as well as separation for some couples. So this has raised all types of issues, and the maladaptive behavior that can be seen in this context could be increased irritation with one another, bickering over small things, sort of getting irritated over little things which would not have taken center stage before. There could be in some cases intimate partner violence as well, and also in some cases a general perception of disconnection with one another. So there need to be a balance between individuality as well as the intimacy here, and the complexity here is many times there are some relational dynamics which have happened already, and perhaps the couples are on the verge of a divorce or settling something. So these COVID times will sort of heighten the feelings of either intense togetherness or disengagement. Somebody has raised their hand, Raghavendra Parekh. Is it that you want to ask a question here? Does somebody want to ask a question or share something here?
Continue.
Pardon?
At the end of the session, we will ask the questions.
All right. So I can continue. All right. Okay, so I'm going to go ahead now. Looking at the psychological issues in relation to elderly persons. Now, older persons may have several physical complaints already. Some of them may be living alone. Some of them are living in flats with some caring community members or relatives around. And there will be some people also in nursing homes. Now, all over the world, we have seen that COVID has particularly had an effect on older adults, not only because of the lower immunity, but also because they may have several pre-existing conditions like respiratory issues, or they may have other chronic diseases which need to be addressed. And COVID-19 has had a very given a very difficult as well as a challenging time. So you will find that some of the things which are associated with elderly people, maladaptive symptoms could be sleeplessness or feeling anxious, boredom also, panic attacks and nightmares. Also feelings of emptiness or a fear of infection, health anxiety could be common, or also a feeling of being imprisoned, anxiety related to the future, as well as grappling with every to death and dying. Some of the factors could be if I die, will there be somebody around me who's going to help me? And my loved ones are so far away. So what can I do? So there's a sense of helplessness in this situation. So you could see many symptoms of depression. You could see anxiety disorders as well as post-traumatic stress disorder. They may have some nightmares or feelings of being attacked at times. And hypochondriasis also can happen where they are so afraid of catching or getting infected by any of the diseases. So, special needs of older adults during COVID-19 need to be addressed in a very different way. So, psychological issues among older adults, and we can also see that a lot of older adults living in isolation, some of the things that have been observed is a cognitive decline or dementia, which is almost higher in elderly groups. You can see more of it now. They could be also overly suspicious and withdrawing, or they could be and agitated as well. So it's there is a deterioration of physical health during this time among the older adults. Okay, so here the other important issues which come up here in a special group here again is the frontline personnel. Now, by frontline personnel, I mean healthcare related personnel, doctors and nurses in particular. It could also be police and government authorities who are so much combating with the effects and consequences of the disease on a daily basis. So the most important part here is that burnout has become quite common among these groups. And when I say burnout, there is a triad. And the triad here is one of emotional exhaustion, dealing with the same issues and feeling more and more exhausted emotionally, and feeling of depersonalization. Here, there is a feeling of being sort of disoriented or away from one's sense of self. There is a loss of empathy or a loss of caring and compassion. This can happen, and also a decreased sense of accomplishment, that the person is continuing to do something or engaging in duties, but there is no outcome or there is no effect. When all of these three get together, or you could have just one or two of these aspects, then it could often lead to burnout. So there are many things which contribute to burnout. Particularly, I'm thinking of nurses, the long work hours, the intense fear of infection. Sometimes there is inadequate PPE available, or the management may not provide adequate PPE for the person. Then several nurses have to stay away from families during this time. They may have young children, or even when you are with them, there may be fear of getting others infected in your family. So several of these features come together and affect the person, relating not only to burnout, but it could also relate to depression and anxiety among the frontline providers. So there are several useful resources online about how you can care for one another, and what are some of the steps that hospital management can take in order to take care of the mental health of nurses and doctors. Okay. I'm going to go on now. Yeah, so these are the psychological after effects. Now, COVID survivors, those of them who have had mild symptoms, those who have moderate and even severe symptoms, apparently many people who are studying these particular groups of people have found that it takes a long time to recover, not only from the physical effects of the disease, but the other psychological effects as well. So one changes. Like there could be changes in attention, there could be changes in memory over the next few months. The persons could also experience the symptoms of PTSD. Several older people also have found that they feel very fatigued. There is a brain fog in which they are very unclear about things around them. It could be for small intervals, it could be for longer intervals as well. There could be sleep disturbances. And among at least around 40% of those who have been in the ICU face a higher risk of delirium after they have come out of the hospital. So these symptoms could be seen a month or two even after the COVID they have been come out of that infection. So special rehabilitation effects need to be taken into context during this particular in these particular cases. Okay. There is also something called post-intensive care syndrome. Now, much of this is seen among survivors and families of survivors, and it relates to mostly those who have been spending a lot of time in ICU. And here you will find that families feel very helpless because they are not able to see the patient, they are not able to contribute in the care of the patient. They have no idea about how things will progress. So a lot of these survivors as well high feelings of anxiety and depression and can psychology information through some other ways in order to
Your voice is breaking.
Yeah. Is it okay now? Can you hear now? Yes. Can you hear me now? We can hear. Okay. So this is the last. I'm coming to the conclusion here. So, though we have talked so much about the maladaptive behavior, it seems a very negative and very dire. And if we focus too much on the maladaptive aspects, then yes.
Sorry, ma'am, your slide is not visible.
Slide is not visible. Okay. I'm going to share the screen again. Can you see it now? Can you see my screen now? Yeah? Okay. So, yeah, so this is the last slide actually. The necessity to build resilience during COVID-19. And though we may think that there's been more of a focus on the maladaptive aspects, let us not forget that resilience is so much is the key to managing issues in COVID-19. All of us have the coping strategies and the resources. Some of us have lesser and some of us have more of a time. It can be a very, very positive time of each other not only personally but as well as collectively. Think of the connections that we have with one another, our families and friends, taking care of yourself, the mind and the body, embracing more healthy thoughts and positivity rather than negativity, and finding purpose. I mean, several people have been using the time of social isolation and quarantine very, very productively. So it can be learning something new, it can be contributing to the lives of others, but whatsoever it is, there are several stories of inspiration and resilience which will help us to tide over this period of COVID-19. So with that, I'd like to conclude this and open up the time for questions and interaction, please.
Very wonderful session, ma'am. I
Yes.
think most of us will very soon be maladaptive and adaptive. Now, in the chat box, we can't see any questions right now. Feedback like very good session, very informative session. That's all, ma'am. I don't think there is any more queries for your session, ma'am.
Okay. Even if it's not a query, it can be just an observation or a reflection. Anybody want to share experiences is also fine.
Next, St. John's College, ma'am. Ma'am has awarded with PhD in clinical psychology from Nagpur University. Madam worked as a rehab psychologist with special needs children in Nagpur for 7 years. Madam is registered with RCI as rehabilitation and clinical psychologist. Madam is also a member of expert committee of RCI and fellow member of ISBR. Madam is especially involved for rights of children with learning disabilities. Madam has also authored 2 books. With this brief introduction, I once again welcome you, ma'am. Ma'am, you can take the topic on cognitive behavior therapy. Over to you, ma'am. Ma'am, you can share your slides, ma'am. Ma'am, please unmute yourself.
Good morning, everyone. Can you hear me now?
Ma'am, please unmute yourself. Ma'am, you're not audible, ma'am.
I have unmuted. It's from the other side. It's not. Can you hear now? Can you hear now? Can you hear?
Can't hear you, ma'am.
Yeah. I have unmuted from my side. Can you please check why the audio is?
Please increase the volume.
Can you please check why the audio is not coming?
No, ma'am, it's not audible. is there any network issue, ma'am? Participants, please just wait for a while. We have some technical issues. We'll be getting you back. So please just please stay with us.
Hello? Can it be heard now? उसमें वही लिख करके आ रहा था, host is not allowing participants to unmute. हाँ, लैपटॉप से हूँ. फुल है, फुल है, फुल है. अभी चेक किया मैंने. हेलो. इस पर मैं ये कर रही. अभी आई क्या आवाज? Yeah, I have unmuted it. अभी आ रहा है? फोन रख दूं मैं फिर? ओके. Good morning, everyone. I hope now you can hear me. Can you hear me now? Yeah?
You may please share your slides, ma'am.
आवाज आ रही है आपको?
Yes, ma'am, we are audible, ma'am. You can share your slides, ma'am.
Okay.
Yes, ma'am, you're audible.
Good morning, everyone. I would like to start with the topic given to me on the cognitive behavioral therapy. But first of all, I would like to thank Aradhna ma'am and Sheetal for coordinating and inviting me to give this talk on cognitive behavioral therapy. Although it is a very lengthy topic, which even 1 hour or 1.5 hours is not sufficient for this topic. But then, yes, I would like to sum up in the gist whatever I can. So to start with, like when we hear the word therapy, usually the first thing that strikes us is like we think of a person sitting on a couch talking to a man with some spectacles or a beard and analyzing your dreams. But actually, CBT, it's actually a very practical type of a talking therapy which focuses on the goals and motives of mostly of the present day and things that are affecting you in your life as of now. And the theory behind CBT is that the way we think about situations can affect the way we feel and behave.
Ma'am, just a minute.
It does this by dealing with how your thoughts affect your feelings.
Excuse me, ma'am. Ma'am, your slide is not visible. Shall we share the slide from our side?
Ah, now you can see the screen also, right? And the voice is audible.
Ma'am, you're audible, ma'am.
Okay. So what I was talking about the CBT is, it is a therapy. The therapist mainly deals with our feelings, thoughts, and the behavior. The next slide, which we can have. The next one. Yes, it deals with our thoughts, feelings, and the behavior. This is what basically is included in the cognitive behavior therapy. The thoughts which create our feelings, and the feelings which create our behavior, and then the behavior again which creates our thoughts. So this is an ongoing process. And then comes our, can we please go on changing it, because like if I was sharing it, I would have controlled it from my end. A bit about the cognitive behavioral therapy as to how it started. Like, it is basically a blend of two therapies, the cognitive therapy and the behavioral therapy. The cognitive therapy was developed by psychotherapist. He was basically a psychiatrist, Aaron Beck, in the 1960s. The cognitive therapy focuses on a person's thoughts and beliefs and how they influence a person's mood and actions, and aims to change a person's thinking to be more adaptive and healthy. Behavioral therapy focuses on a person's actions and aims to change the unhealthy behavior patterns. So, CBT helps a person focus on his or her current problems and how to solve them. But both patient and therapist need to be actively involved in this process. The therapist helps the patient learn how to identify the distorted or the unhelpful thinking patterns, recognize and change the inaccurate beliefs, relate to others, nurturing the positive ways and change behavior accordingly. A little about Aaron Beck's history as to how it was developed and how Aaron Beck he started with a cognitive behavior therapy. It's a although a relatively new mode of and it's a very short-term psychotherapy. It is developed for treatment of depression and anxiety, but now it is widely applied to many broader range of the mental disorders. It is based on the premise that our moods and feelings are influenced basically by our thoughts. Now, a bit about Aaron Beck. Aaron Beck was a psychoanalytic psychotherapist, and in the early 1960s, Aaron Beck developed an approach known as cognitive therapy as a result of his research on depression. Then Aaron Beck observed his observations of the depressed clients revealed that they had a negative bias in their interpretation of certain life events, which contributed to their cognitive distortion. And Beck basically called it cognitive therapy because of the importance it places on thinking. It's now known as the cognitive behavioral therapy because the therapy employs the behavioral techniques as well. Therefore, now as we use it, it is overall known as the cognitive behavioral therapy. The overall, the five things that we include in it are the feelings that leads to our stress, it's the thoughts that I'm able to manage or I'm not able to manage. Then that leads to our feelings of the improved mood, the helpful thoughts, the our behavioral, our behavior, which again leads to the relaxation techniques. So the basic five parts of CBT are the situation, the thoughts, our physical feelings, the emotions, and then comes our actions. So the first thing that we talk is the situation. What triggers the problems? Supposing we are criticized at work, so that now has triggered the problem. That comes to our thoughts. What goes through basically our head? That I'm not good enough. And then that comes both it intersects with our emotions and our physical reactions. Emotions is how do we feel about it? Whether we feel worthless or we are anxious about it. Then the physical reactions, how does my body react to it? Maybe I have a loss of appetite or feel tired about it. And then that leads to our behavior. What do I do? Avoid contact with others. The basic fundamental assumptions about the CBT. It is based on the premise that the way a person perceives an event rather than the event itself determines its relevance and the response to it. It is time limited, attempting to cause change rapidly and often within an established time frame. Therapeutic change can be effected through an alteration. Now, these therapies are basically based on the belief that patients are the architects of their own misfortune and have control over their thoughts and actions. So, therefore, that can be monitored and changed. They also help the patient learn something about the process of therapy and develop therapeutic skills applicable to the other problems. It also aims at altering the cognitions for effecting a change in behavior. It implies that all psychiatric disorders have some amount of cognition, and an improvement in this enhances the patient's recovery. Now, when we talk of the duration of cognitive therapy, basically there is no such fixed time frame, but usually a typical the cognitive therapy schedule is it consists of 15 visits or over a period of 3 months. But then again, any of the therapies they are basically tailor made. Now we come to the goal setting thing. Why set goals for the therapy? Basically, CBT is a time limited. Setting some specific goals ensures that we work with a focus and clients get the most out of the therapy. It also allows to track the progress in therapy. goals are based on the client's expectations for the therapy. What would you like to accomplish in therapy, and what would you like to be different in your life? Then there are some general goals, and then we have the specific goals. Overall areas that need improvement are: I want to be healthier, I want to take better care of myself, or I want to have friends. And the specific may be observable and reasonable changes that can be measured. What can we do to start? Like small little steps with the specific goals. And the main areas that have to be seen, that the goal setting, it has to be specific, it should be measurable, it should be achievable, realistic, and time limited. Questions are: where are you now, where you would like to get, and small steps can you to take from where you are now to where you want to be. It is on our own when we can start it off. We can practice with setting up of our goals, define general goals, and we have to prioritize our three, the ones that would give most immediate relief. For each goal, we have to see where are you now, where would you like to be, define small, reasonable, achievable, measurable steps to talk. It is basically, we have to see it is worked out with the therapist and the client together. And the rate level of difficulty of each step, arrange according to the level of difficulty, starting from the easiest. Ask what would be the first sign that you are making progress. Practice setting up 8 small steps towards a specific goals. Then we have our automatic thoughts. These are the thoughts that pop up into our heads automatically throughout the day, and we don't have the intention of having them. Usually, we are not even aware of them. One of the goals of cognitive therapy is to bring these automatic thoughts into awareness. If you are late for an appointment, what would you think as you are traveling to get there? So basically, we have to learn to identify these automatic thoughts. Some basic questions for it are: what was going through your mind when you had that strong feeling or reaction for whatever reason and any problem the client has come to you? Ask this question when you notice a shift in effect during a session. Have the client desirable a problematic situation or a time during which he or she has experienced a shift in effect? If needed, then only use the imagery to describe the situation in detail. Or because then the client has to actually imagine as if it's happening now. If needed, have the client role play a specific interactions. And a few other questions which are there to elicit the automatic thoughts are: what do you guess you were thinking about? What did the situation mean to you? And what images or memories did you have in this situation? What were you afraid might happen? Or what were you exactly thinking? What are the cognitions we evaluate in the therapy? So these are the basic evaluation. Like I told earlier, this is a very elaborative therapy. Like even for our PG students, when we teach them, just the CBT, it takes almost 1 week to teach them and then to practice it. We have to really understand it, the different areas, the interpretations, the predictions, the labels, the meanings, judgments, and everything that we have to go through about when we are trying to evaluate whatever we are trying to evaluate in the therapy. Then we have to talk about the hot thoughts. It is the thought that is more emotionally charged, strongly connected with the emotional shift. Is the thought that triggers the mood change, and it appears very spontaneously during the day. It can be words, images, or memories. We circle the hot thought in the thought record and focus on it. So these are basically the hot thoughts are the thoughts which is troubling the client that has come to you. This is basically the chart how we have to make it. As of now, we can't practice it because of lack of time. Now, the evidence that supports the hot thought. We ask for the facts, the things that actually happened in the past. This includes the situations, the experiences, the reactions, consequences of it. We don't write those down ideas, interpretations, facts, or thoughts. this we can skip. It is how to create the balanced of alternative hot thought. Basically, this is, I just want to give a very outline of the CBT, because all these things are very much in detail when we actually understand as to what CBT is and how we are going to practice it. These are some of the cognitive the distortion of the negative thinking. Any client that has come to you, see, any person going through a negative thinking is disturbed about it, then only the client comes to a therapist. So these are few of the distortions, that all or nothing thinking. You view a situation in only two categories instead of a continuum. If I'm not a total success, I'm a failure. Because the client is going through a bad phase, if no success, then a total failure. They don't see the middle part of it. Then the catastrophizing. You predict the future negatively without even considering other more likely outcomes. I'll be so upset, I won't be able to function at all. Anything goes wrong, and we just come to the utmost negative thing of it, disqualifying or discounting the positive. You unreasonably tell yourself that positive experiences or qualities do not count. I did that project well, but that doesn't mean I'm competent. I just got lucky. This is a negative way we feel about ourselves. And these are some of the things which even you and I, we often go through it. But then, yes, we get over it and we see the positive part of it. Therefore, as of now, we don't have to visit a therapist. Then is the emotional reasoning. You think something must be true because you feel, and actually you believe it so strongly, ignoring or discounting evidence to the contrary. I know I do a lot of things okay at work, but I still feel like a failure. And then comes the labeling. So this is all the cognitive distortions that the client or even we ourselves we go through about it. Now, when we talk of the elements of CBT, of the cognitive behavioral therapy, it has got several defining elements. There, few of them are as follows. The first is the active. The client must be involved in the therapeutic process not as an observer or as an occasional visitor, but as a core and key participant. The motivational part of it, the therapist needs to take responsibility for helping to motivate the client towards a change in behavior, effect, or thinking. The therapist must be able to set up the format and rationale for the client to consider change of value. Directive is that the therapist must be able to develop a treatment plan and then to help the client to understand, contribute to, and see the treatment plan as a template for change. Should be the structure should be the CBT is structured in basically two ways. First, the overall therapy follows structure that approximates the treatment plan. Then the sessions have then identifiable beginning, middle, and the end. Then the therapeutic collaboration cannot be just 50-50 for severe or depressed clients. It has to be the collaboration maybe 90 and 10. For each client, the therapist must evaluate the client's ability and motivation for the therapy. It basically again depends on the client. And the CBT focuses on discrete problems rather than vague, because we need to have specific goals, and we have to see that ultimately the self-esteem of the client has to increase. The other elements of CBT is the therapist works as a change agent. Many two problems that bring people therapy involves skills deficits. The therapist may have to teach by direct instructions, modeling, or role playing. Solution focused. The CBT therapist works with the client on generating solutions, not simply gaining insight into the problem. And the dynamic level of CBT is to help clients to identify, understand, modify their schema. The schema are the basic templates for understanding one's world. Schema may be personal, religious, cultural, or gender related. Then the time limit of the therapy is each therapy session should ideally stand alone. A time limited focus is not the number of sessions, but rather way of looking at the therapy. Like even earlier I said, it is not uh, any fixed time limit. It's all tailor made. Then the basic techniques of CBT. The cognitive behavioral therapy techniques are an interesting set of exercises that help modify a person's behavioral patterns. The behavioral patterns are modified in order to bring about positive changes in the personality. One is the cognitive rehearsal. In this technique, the patient is asked to recall a problematic situation of the past. Then the therapist and client both work together to find out a solution for the problem or a way in which the difficult situation, if it occurs in the future, can be sorted out. The therapist asks the client to rehearse positive thoughts cognitively in order to make appropriate changes to the latter's thought process. And the power of imagination proves to be of great use in this exercise. Then comes the validity testing. In this technique, the therapist tests the validity of the beliefs and the thoughts of the client. The client is allowed to defend his viewpoint by means of objective evidence. The faulty nature or invalidity of the beliefs of the client is exposed if he or she is unable to produce any kind of objective evidence. Then the next technique is the writing in a journal. It is the practice of maintaining a diary to keep an account of situations that arise in the day to day life. Thoughts that are associated with these situations and the behavior exhibited in response to them are also mentioned in the diary. The therapist and client together review the matter written in the journal. It is basically a joint exercise of the therapist and the client. And then they together try to find out the maladaptive thought pattern. The discussion that takes place between them proves to be useful in finding different ways in which behavior of the client gets affected. The next technique is the guided discovery. The objective or purpose behind using this technique is that of helping clients by enabling them to understand their cognitive distortions. Clients are made aware of and assisted by therapists in understanding how they process the information. The activity of understanding how information is processed allows clients to alter the same if it is required. Basically, the client's perception of the world undergoes great change and he or she sees things in a different way than earlier. This change in perception allows the client to modify his behavior in a better manner. Then the next technique of CBT is modeling. It is one of the cognitive therapy techniques in which the therapist performs role playing exercises, which is aimed at responding in a way that is helpful to overcome difficult situations. The patient makes use of this behavior of the therapist as a model in order to solve the problems which he or she comes across. Then the other technique is basically the homework. The homework is actually a set of assignments given by the therapist to the patient. The patient may have to take notes during session with therapist, review the audio tapes of a particular session, or read the articles, books related to the therapy. The next one is the aversive conditioning. Among the different CBT techniques used by therapists, the aversive conditioning techniques makes use of dissuasion as to lessen the appeal of a maladaptive behavior. In this, the patient, while being engaged in a particular behavior or thought for which he has to be treated, is exposed to an unpleasant stimulus. Thus, unpleasant stimulus gets associated with these thoughts and behavior, and then the patient exhibits an aversive behavior towards them. The next one is the systematic positive reinforcement. It is one of the techniques of CBT in which certain positive behavior of a person are rewarded with positive reinforcement. A reinforcement system is established for the certain positive behavior. Just like positive reinforcement proves to be helpful in encouraging a particular behavior, withholding the reinforcement deliberately also is instrumental in eradicating a maladaptive behavior. Then it's the self instructional methods. In self-instructional coping methods, the therapist attempts not to completely change the way you think, but rather teaches coping methods that equip you to handle the harmful thought process. One such therapeutic process is stress inoculation training. Now, all these are may sound quite heavy words for you if you are listening it for the first time, because this again needs too much of explanation as to what it is. This therapy helps the patient deal with stressful events, aims to prevent the negative reactions to stress inducing factors by teaching the patient to break down these situations into short term and long term coping goals. The next is the problem solving methods. The cognitive therapy, which sees irrational thought process as resolvable, incorporates problem solving methods. After illogical thought patterns are found, the patient must suggest several alternative situations and the solutions. Through the decision making process, negative solutions are weeded out until an acceptable and positive approach is discovered. This type of therapy sometimes is used in child psychotherapy when dealing with oppositional defiant disorders. The next is the computer assisted therapy. This is a new one in the method of conducting the CBT through computer based programs. Now, this therapy tends to decrease the time spent with an actual therapist, but this is not much of use as of now here with us. Now, the cognitive therapy, the CGTP, it was adapted basically for the patients of depression, but later it did expand to the other mental disorders too. Now, when we talk for depression, like many studies have shown that CBT is particularly effective treatment for depression, especially minor or moderate depression. Some people with depression may be successfully treated with CBT only. Others may need both CBT and medication. CBT helps people with depression restructure the negative thought patterns. Doing so helps people interpret their environment and interactions with others in a positive and realistic way. It may also help a person recognize things that may be contributing to the depression and help him change their behavior that may making the depression worse. Then as we talk of CBT for the anxiety disorders, in anxiety disorders, it aims to help a person develop a more adaptive response to a fear. A CBT therapist may use exposure therapy to treat certain anxiety disorders, such as a specific phobia, a post traumatic stress disorder, or the OCD. Exposure therapy has been found to be effective in treating the anxiety related disorders. It works by helping a person confront a specific fear or memory while in a safe and supportive environment. The main goals of exposure therapy are to help the patient learn that anxiety can lessen over time and give him or her the tools to cope with fear or traumatic memories. A recent study sponsored by the Center for Disease Control and Prevention concluded that CBT is effective in treating trauma related disorders in children and the teens. Then CBT, we have it for the bipolar disorder also. People with bipolar disorder usually need to take medication, some mood stabilizers, but CBT is often used as an added treatment. The medication can help stabilize a person's mood so that he or she is receptive to psychotherapy and can get the most out of it. CBT can help a person cope with the symptoms and learn to recognize when a mood shift is about to occur. CBT also helps a person with bipolar disorder and stick with the treatment to plan to reduce the chances of the relapse. Then CBT for the eating disorders. Eating disorders can be very difficult to treat. However, some small studies have found that CBT can help reduce the risk of relapse in adults with the anorexia which have distorted their weight, and CBT may also reduce some symptoms of bulimia, and it may also help some people reduce the eating behavior. And then CBT is also used for the schizophrenia. Now, treating schizophrenia with CBT is actually a challenging work. The disorder usually requires medication first, but research has shown that CBT is an add-on to the medication and can help a patient cope with schizophrenia. CBT helps patients learn more adaptive and realistic interpretation of events. Patients are also taught various coping techniques for dealing with the voices or other hallucinations. They learn how to identify what triggers their episodes of the illness, which can prevent or reduce the chance of or relapse. CBT for schizophrenia also stresses skill oriented therapy. Patient learn skills to cope with life's challenges. The therapist teaches the social, the daily functioning, and problem solving skills. This can help patients with schizophrenia minimize the types of stress that can lead to outbursts and the hospitalization. See, as I told you that CBT was originally designed to treat depression, but now CBT is used in all these other disorders, which even includes the take the other psychotic disorders also. So this is where our CBT works. The other part, the main focus of the CBT, which I would have loved to talk about the ABC model of CBT, but ABC model again takes a very lengthy time to explain as to what it is. I hope just the gist of it would be of some help, and later sometime we can really have very a detailed um, workshop rather on CBT, which can be really useful for the nursing staff, because you people really deal with the patients, and it is not just with the physical problem. Ultimately, it is with the psychological problems too. So thank you.
Ma'am, it was really a very wonderful session. I think we are very well clear with the CBT and its medical uses as well. Ma'am, just a second, I'll just see if there are any queries or not. We are receiving the feedback that it was really informative session, and they are very clear with the topic that is CBT. There are no more doubts, ma'am. I think all are very happy with your session. Thank you, ma'am, for your wonderful session. So moving over to the next session, that is on normal and abnormal behavior, role of a nurse, which would be taken by eminent speaker, Ms. Sulekha B, Principal, School of Nursing, Noor Memorial Hospital, Nagpur. Ma'am is also nursing superintendent and hospital quality coordinator with more than 13 years of experience in the field of teaching, research, and administration. Madam coordinated German Westward volunteer program of government of Germany from September 2011 to 2015. Ma'am has been appointed as coordinator with Noor Memorial Hospital, Nagpur. Madam completed her PG from Christian Medical College, Vellore, Tamil Nadu in 2009. At present, Madam is pursuing postgraduate diploma in healthcare quality management course from Tata Institute of Social Science, Mumbai. Madam also served as internal counselor program on NABH standards conducted by Quality Council of India and NABH in December 2012. Madam is also a life member of TMAI, CMAI, and ISCM. Ma'am also give her expert guidance for the various research projects. We proudly welcome you, ma'am. Over to you, ma'am. You can start with your session.
Hello. Hello.
We can see you. But ma'am, can you say something so that we could know that your voice is audible?
Hello. Am I audible?
Yes, ma'am.
My screen is open, right?
And the screen is also visible.
Yeah, sure. Thank you so much. Good morning to all, and I would like to thank the. Uh, hello?
Ma'am, slide show, ma'am.
Hello? Hello?
Yes, ma'am, you're audible, ma'am. Ma'am, can you put your
My,
presentation in slide show?
hello?
Ma'am,
Yeah. Now, am I audible?
yes, ma'am, you're audible.
Uh,
Yes, ma'am, you're audible. Ma'am, can you put your presentation in slide show?
there is some technical issues actually. Okay, I would like to thank the principal of Chaitram College of Nursing and all the faculties and also the organizing committee for giving me the opportunity for sharing this knowledge. And thank you so much once again. And going ahead with the topic, my topic is like concepts of normal and abnormal behavior and the nurse's role in it. So to start with the understanding the normal and the abnormal behavior and the nurse's role, like the normal and abnormal behavior. The behavior is such like we cannot actually understand what is normal and abnormal behavior. Like for a few years ago, like some of the behaviors which was considered abnormal is now considered as normal. So in this ever changing the world, in ever changing society norms and things like that, the whole world is changing so rapidly and crazy world, and it is very difficult to understand what is normalcy and abnormal, what is normal behavior and abnormal behavior. So going ahead with the next slide, I have got some descriptions of some behaviors over here. So when you see, can you just take a minute to read on the screen? These are some of the descriptions of some behaviors which is there, like a man kissing another man, a 16-year-old girl who chooses to dye her hair a bright lime color. And what if a 70-year-old does the same? Or a man barking like a dog, or a woman slapping a child, a woman refusing to eat for several days, a man driving a nail through his neck. So these are some of the descriptions. So when we see all these behaviors, or can we say, yes, this is abnormal behavior, or can we say, yes, this is a normal behavior? So in order to understand whether this is a normal behavior and abnormal behavior, we have to consider a lot of things. So like the background of the situation, a man kissing a man, that may be a cultural issue, cultural thing, or it's a family thing or gathering, or we have to consider these things like the background of the situation or the event, what it is happening there, and socio-cultural aspects where the individual comes from, the family or the ethnicity of the person, the race, the age and the sex, like coloring the hair. The age group, 16-year-old girl colors her hair, it is normal because now it is considered as normal. Few years ago it was abnormal, but now coloring the hair like a bright green or pink or green or anything, so that is normal now in this present situation or society. But few years ago it was abnormal. So the same thing if a 70-year-old man does, it is abnormal. So we have to consider when there is a very thin line between the normal behavior and the abnormal behavior to judge whether it is a normal behavior and abnormal behavior. So going ahead, what is a normal behavior? First we'll see the normal behavior and then we'll go on to the abnormal behavior. So a normal behavior, as such, the word itself indicates that's a norm. It's a norm. Norm means it's a rule or a set of pattern or a standards which is being laid down. So behavior is something which is manifestation of a personality. So how the person is made, how the individual is made up of, what are the qualities, the attitudes, the behavior, the way of speaking, all those things. So to understand there is no, the definition of normal behavior, it differs, actually differs from person to person, time, space, as I said in the earlier slide. So we have to consider all those things to know what is normal behavior. So we have been seeing the models of behavior from past 2 days, that many, Dr. Deepti ma'am and Priya ma'am and Priyanka ma'am, so many people have explained, Priscilla ma'am explained all these models very clearly. How these models have applied or to explain the behavior. So there is psychoanalytical model. Psychoanalytical model is given by Sigmund Freud, and which is talks basically on the id, ego, and superego. So a normal behavior is one that when you have a balance between the id, ego, and superego. When we have a balance between the id, ego, and superego, we have a normal behavior. And behavioral model says that all the behaviors are learned behavior. Every behavior that what we does, it is learned behavior, and it can also be unlearned. So all these behaviors are that we learn from our childhood. So it is basically talks about conditioning and operant conditioning and things like that. So the cognitive models actually, the earlier ma'am, the Priyanka ma'am was explained about cognitive behavioral therapy also. So cognitive model, it explains about the thoughts, emotions, and behavior. And what our thinking is, the same thing is our emotion, and what our emotions is the same thing is our behavior. So they are in congruent with each other. So when we are in congruent, when there is a connection between the thoughts, behavior, and emotions, then we have a normal behavior. So if it is in mental illness, we have to understand if the thoughts are saying something and the emotion are something and the behavior is something. So there is an imbalance between these three. It is thoughts, behavior, and emotions. But whereas in normal behavior, when we have to say that is a normal behavior, so there should be a balance between, there should be a connection between, there is a connectedness between the thoughts, behavior, and the emotions. To understand this, there is Beck model is there, to where he says a situation like there is automatic thoughts or images that comes into our mind, and there is a situation or there is some thoughts that comes, like thought comes because of our previous experiences or already preconceived ideas or assumptions, things like that. So according to the preconceived ideas and assumptions, our reaction comes. Our reactions are three things, that is emotional reaction, behavioral reaction, and the physiological reaction. So to understand this, for example, it's a real life scenario, that is a girl looking at a bee coming near to her, which is going to sting her. So sorry. Sorry for that. The situation is that, and then the automatic thought, when the bee is approaching her, the thoughts are like, oh, am I going to die with anaphylactic shock, or maybe I that is going to give me a very bad uh, reaction or something. So what will be the girl's reaction? Emotionally she becomes anxious, and behaviorally she becomes or fearful emotionally, and she started screaming and she started crying and things like that. Behaviorally, like she can run away or she becomes restless, and physiologically our heart rate increases, her breathlessness occurs, and things like that. So this is how a cognitive model tells. So all our behavior are because of our thinking. So next, uh, a healthy personality. Like when we say behavior should be a normal, so behavior is the representation of your personality. So if you have a normal personality, then you have a normal behavior. So why we require this healthy personality? It is important for our happiness, peace of mind, personal judgments, how we make the decision makings, successful living. So basically, a healthy personality is required for all these reasons. So to understand this normal behavior, so we have got this model, or this is some criteria. These are some of the criteria which is given by the Gordon Allport. I have taken this criteria from the psychologist name Gordon Allport, which he gave in 1955, and he basically gave 7 criteria of a normally healthy person. So that is extension of self, warm relating of self to others, emotional security, realistic perception, skills in assignments, self objectification, and philosophy of life. So to going ahead to understand is what is extension of sense of self. So sense of self, how you are applying yourself to the world or to the where you are living, like how you are personally involving yourself or participating in your day-to-day activities or meaningful activities of life, how you are investing yourself in the meaningful activities of life and in family work, leisure, with the friends or other aspects of life. So you are extending yourself to the roles and responsibility that is given to you in the society. So as you participate, as you extend yourself, the more healthier you will be. That is what the Golden Alport says. The next criteria is warmth, warm relating of self to others. So in this we have two things, two criteria, that is capacity of for compassion, capacity of intimacy. Capacity for intimacy is love. Is intimacy means love for your parents, love for your spouse, love for your children, love for your close friends, and basically you have a love, a feeling of love and compassion, and basically a love for the other people around you. And capacity for compassion means how you have a heart which understand the others. You understand the others, other human being, the needs of the other human being, and then you extend yourself, you go ahead to help the person. So that is capacity for compassion. For example, now in this corona situation, many people came ahead to help the migrant workers or things like this, right? Because they had a capacity for compassion. So this is two things, that is capacity for intimacy and capacity for compassion. So next is emotional security. Emotional security, three things are there. So emotional security, it is basically self-acceptance, frustration tolerance, and emotional control. So self-acceptance is you understand yourself and you accept your what you are doing is right, what you are doing is wrong, my weaknesses and your failings. You accept, you take the responsibility of yourself. So that is self-acceptance. And frustration tolerance is how best you can tolerate the stress in your life, how you use your coping mechanisms to overcome your stress, and you become tolerant, and these frustrations and your all these negative feelings will not affect you much, but you overcome it with your own ways of how you cope with this situation. So, and next third thing is in emotional security, emotional control. How you control your emotions, how your anger or sadness or your happiness, how you control your emotions. Next is reality perception. So reality perception is one of the main thing in of a normally healthy human being. So in a normal healthy human being understand the world in a real way, and he objectively assesses it and he accepts the reality. Like for example, in schizophrenia, it is reality perception gets affected, but he doesn't live in a fantasy world. A normal human being doesn't, he will not live in a fantasy world, but he lives in a real world. So that is reality perception. So next is skills and assignments. So what every person has got their own talents and skills that is given to them. So how he utilizes those skills to fulfill the roles and responsibility of his life. So that is what all the assignments that is given to him, that he fulfills using his skills. So next is self-objectification. So self-objectification is mainly self-insight. You have the insight about yourself. Who are you? What really is your strengths and weaknesses? When you know about yourself and accordingly you behave. So that is self-objectification. And the last criteria for a normally healthy person is unifying philosophy of life. He has got some philosophy of life, right? He has got some values that motivates him to go ahead and become a normal healthy person. So I have to behave in such a way, like basically superego. Okay, so like, so these are all the 7 criteria for um, having a normally healthy person. So these are main criteria for a normal behavior. So going ahead to the abnormal behavior. What is abnormal behavior? Abnormal behavior is a behavior that is disturbing, socially unacceptable, distressing, maladaptive, self-defeating, and often results of distorted thoughts or cognitions. So to understand this abnormal behavior, again, like many people or many from ages, they have tried to explain this. They have given so many names to say abnormal. Some say it is unstable in years ago, like madness. You can see insanity, distressed man, or disturbed, crazy, and psychological unbalance, nuts, mental illness, mentally abnormal psychopathology, psychiatric management. So many names which was given to a abnormal behavior. So to understand abnormal behavior, there are different models which explains abnormal behavior. That is medical. There are different concepts to understand what is abnormal behavior. Medical perspective, psychodynamic perspective, behavioral perspective, cognitive perspective, and socio-cultural perspective. So in medical perspective, mainly it is like mainly because of your organicity. Like there is abnormal structures of the brain, there is imbalance in the neurotransmitters, endocrinal system, there is imbalance in the endocrinal system, things like that. So this is basically talks about your biological or your genetic chromosomal abnormality. So these are all explained in the medical perspective. So if there is abnormality in that in the brain, in the central nervous system or endocrinal system or chromosomal or genetic problem. So there is a abnormal behavior. So psychodynamic perspective here it explains mainly uh, there is an with ego and super ego. There is a segment for mainly he talks about psychodynamic thing. It tells us that abnormal behavior is because of the unconscious conflicts that is there, or in the childhood the child has developed some abnormal parenting styles, or there is a like social factors, like the child has come from a war-prone area and things like that. So the child has developed some inner conflicts within himself, which which it is repressed in the unconscious mind, and when he becomes an adult, that is all reflected in the behavior. So that is the reason why abnormal behavior. So that is how the psychodynamic theory talks about. Behavioral perspective is mainly because all the behaviors, as I told you earlier, that all the behaviors are learned behavior, and all this in abnormal behaviors are all maladaptive behaviors. There is some maladaptive behavior which is developed in the childhood, and it is developed and become as a personality. So this is how the behavioral perspectives view as an abnormal behaviors. All the abnormal behaviors are maladaptive behaviors, which also can be unlearned. Like earlier, ma'am was talking about behavioral therapy. So in the behavioral therapy, basically they unlearn the maladaptive behavior. So cognitive perspective, again, the earlier triangle which you did, the thoughts, the emotions, and the behavior. So in cognitive perspective, again, there is some abnormal assumptions, abnormal thoughts, or wrong assumptions, prejudiced ideas which is present. Because of that, the person is thinking abnormally, and that is how he is behaving abnormally. So socio-cultural perspective, again, low socio-economic status and things like that will affect you. That causes the or abnormal behavior. So this is what the models or the perspectives of abnormal behavior. We'll see the case study later. To understand this abnormal, to diagnose the abnormal behavior, we have to understand this something known as 4Ds of abnormal behavior. 4Ds of abnormal behavior. So the first one is deviance. So deviance is this is basically this is used for the diagnosis purpose, like whether abnormal behavior is because of the mental illness. So the deviance. First one is deviance. How, like as you are seeing in this picture, some of the culture again, it is all because of the socio-cultural norms. Like away from the social, how away is your behavior? How deviant? How away is your behavior? That states your abnormality. So it violates the social norms. It violates some of the behaviors, like for example, which you're seeing in this picture. This is in that ethnicity or African race, it is normal. But if it is done in India or somewhere, it is abnormal. So, but in that culture, it is normal. But here, it is deviant. It is away from the social norms, and it is causing anxiety, or it is troubling the other person. When it troubles the other person moving around, then it is a deviant behavior. So statistically speaking, how unusual it is in the general population. Like statistically, it is not found in a general population. So this big type of behavior, then it is called as deviant behavior. So highly deviant behaviors, examples are like chronic lying and stealing. And these are all some of the, this is how the deviance is explained. Next D is dysfunctional. So dysfunctional indicates abnormal behavior elevated markedly to the point to which it is interfering in daily living. So he cannot function normally. He cannot perform his activities of daily living. He cannot groom himself. He cannot put his dresses. He is not brushing his teeth. He is not eating, or with the woman, if he is not cooking the food, or she is not feeding the family, or things like he's like social life. He is not going out, and it is affecting the whole the human being is a biopsychosocial being. So all this biological aspects and social aspects, psychology, all it is causing it is having a bad impact. He cannot function normally. So what all functions? He is not going to the job. He is not occupationally functioning. So these are all, if it is affecting the activities of daily living, then it is called as dysfunctional. So if abnormal behavior is considered as is affecting the or interfering in the activities of daily living, then it is called as dysfunctional behavior, or it has got a negative impact on the multiple facets of the individual. So that is second D. And the third D is danger. The two things are there in the danger, that is danger to self and danger to others. So if his abnormal behavior becomes self-destructive, he is violent or aggressive, and he is trying to take a sharp knife and hitting somebody, or trying to kill someone, or cut hand or something, then it becomes a danger. Then it is called as abnormal behavior. So that is how dangerous is the abnormal behavior. Then it is diagnosed as mentally, that person is mentally ill. Next one is distress. Distress and dysfunction are related to each other. If you are dysfunctional, if you are not functioning your life properly, if the activities of daily living is affected, your occupational functioning is affected, your social functioning is affected, it causes distress in the individual. It can be subjective feeling of distress, how distress you feel. And this distress is exhibited in body pains or body symptoms or agitation, depression, or some biological needs are decreased, and disturbance in the sleep, anxiety, things like that. So how disturbed you are. So that is called as distress. So 4Ds of abnormal behavior, that is deviance, dysfunction, danger, and distress. So this is 4D, and another D is also added, that is duration. How for how long this abnormal behavior is present in the person. So this is basically abnormal behavior. To diagnose as abnormal behavior, these 4 criteria are used. That is deviance, dysfunction, then danger, and distress, and duration. So these are support these of abnormal behavior. Going on to the next one, going on to the nurse's role. What is nurse's role in this abnormal behavior? How as we are nurses, how we have to take care of the abnormally uh, abnormal behaviors. So usually abnormal behavior causes uh, a distress, or it doesn't, like, not everyone feels good to see an abnormal behavior. So what is the reaction? Basically, a nurse, when she sees abnormal reactions are also matter. So some of the reactions of a nurse towards the abnormal behavior is she becomes anger towards the abnormal person, or repulsive, or she is surprised why he is behaving, or shocked. Sometimes suddenly he slaps somebody. So she becomes shocked, threatened. Sometimes if it is dangerous, the person becomes violent and agitated. It becomes threatening situation. So the nurse becomes threatened, confused. Sometimes she feels pity on the person or sympathy, or sometimes the nurses also can develop a non-caring attitude towards the abnormal person. So the next, some, because of this, the nurses tend to have some type of stigma towards the abnormal behaviors. So this stigma to be avoided. So this nurses, as a nurses, mental health workers, or psychiatric nurse should avoid the stigma within herself. So what is the stigma? Stigma is these are the things that explains what a stigma is. What are the stigma associated with abnormal behaviors? Labeling the abnormal behavior, abnormal problems, or behavioral problems. Like we tend to label the person like, he is a psycho, wacko, or he's admitting again, he's crazy, he must be not, he must be out of this medication, that's why he came back again. So labeling the behavioral problem should be avoided. And next one is stereotyping. Like all are same, all psychiatric people are same, all abnormal behaviors are same, all drunkards are same, he will come back again after a few days, things like that. So like these type of stereotyping should be avoided. And then creating a division, like we are nurses, and they, that is psychiatric patients, they are behaving like this. So we should not have we and they groups. And then like I am not going into that room. Like for example, it is given, I am not going into the psycho's room, she is so rude, she comes, like she can feel herself, things like that. So this type of stigma towards the abnormal behavior, developing this attitudes like labeling, stereotyping, creating divisions, and discriminating should be avoided when we are taking care of abnormal behavioral problems of the psychiatric patients. So first, we'll see assessing the client's appearance, mood, psychomotor behaviors. So first, as in nursing process, so first we are assessing. Before we do anything, we have to assess. So for in psychiatric or abnormally behavioral problems, also what we are supposed to observe when the patient comes to us. So first one is patient's appearance is monitored. So patient's appearance, mood, and psychomotor behavior. So how patient of the person, gait, gait of the person, how he comes, how he walked and came, how he what are personal hygiene, whether the person is maintained his personal hygiene, grooming. So this gives lot of information, data regarding the person. We can assess very easily what is the reason behind it. Also, it helps in our diagnosis also. So this is about appearance of the uh, appearance, assessing the appearance. Next one is mood and affect, monitored by how the person's mood is, how interpreting the verbal and non-verbal communication. What the person, the patient, person, the psychiatric person comes abnormal, person comes with sometimes to us, and he exhibits some of the verbal and non-verbal, like some person comes facing, some person comes happy or elated, sober, sad, and it gives us the idea that what is the mood of the person. So next one is making eye contact, facial grimaces, whether the person is maintaining the eye contact. These are all things are this is also assessed in a mental status examination, but assessing as soon as the person comes to us to a psychiatric ward or healthcare facility, these are all things to be assessed quickly. It gives a cues or it gives the data very fast. So the nurses should be very quick to understand these are all this um, assessments. Whether the person is making an eye contact, facial grimaces, he making faces or unusual sounds, or his psychomotor body movements, how he whether he is restless. All these things to be assessed quickly to make the diagnosis. Next one is identifying, responding to inappropriate and abnormal behavior. Identify behavior whether it is disruptive or dangerous. Quickly, we have to assess whether the person is dangerous or disruptive. Disruptive behaviors are one which is like example is given here, like client yelling out and invading the personal space of another person. So client is shouting. It is disruptive behavior. Dangerous behavior is, as I told you, he is violent, aggressive, and clenching his teeth, and he's going to punch. He's holding his fist tightly, and he's going to hit somebody. So this is dangerous behavior. So destructive behavior is identify quickly what type of behavior the person is. The behavior, whether it is disruptive or whether it is dangerous. So we have to identify it quickly. And also we have, when we are identifying this type of abnormal behavior, nurses also have to consider what is causing that behavior, environmental conditions or physical psychological factors or social factors that is triggering. So some of the factors that triggers, like maybe the person is there is overcrowding of the thing, so that type of overcrowding is there, or some people are talking to each other, or there is visitors and the doctors are all coming and nurses are talking to each other and things like these type of things, or bright light or things like that, the sounds are coming, noises. So these are all things that can trigger the abnormal behavior, dangerous or destructive behaviors in some of the psychiatric patients, especially in paranoid schizophrenia. The person becomes suspicious or the person can become dangerous. So when we are assessing, we also have to assess the environmental condition and what are the factors that is triggering or provoking the abnormal behavior. Next one is, after assessing, identifying, and assisting the client with achieving the self-control. How we can help the person to attain the self-control of the behavior, abnormal behavior. These are some of the preventive measures. So preventive measures like we have to keep the environment safe and then supportive to the person. Like we have to keep the room safe, away from the sharp instruments should be like some people become suicidal and things like that. So we have to provide, these are all some of the preventive measures. The nurse's role is very important in this, keeping away, quickly the room where the person is staying, or he should not harm somebody or harm himself also. So these are things, preventive measures. Other preventive measures specific to the client's needs include some of the preventive measures that can be taught to the person with the abnormal behaviors are like encouraging stress and relaxation techniques. Lot of techniques are there for stress relieving, meditations and yoga and muscle relaxation, deep breathing exercises that can be taught to the persons. And then maintaining consistent environment, consistent schedules and routines. Like many psychiatric patients get triggered when it is like suddenly if somebody comes into their rooms. So all the things like giving the medication should be at the same time, or the rounds, the usual rounds should be at the same time. The schedules that they make, like for example, going into the therapy or going into the, it is like everything. There should be a routine. The routine should be known to the psychiatric patients. Otherwise, the persons become distressed. Like it disturbs himself, and if it disturbs his emotions, then again his behavior also changes. So that's why we have to maintain a consistency in our care. There should be consistency of medication, consistency in the therapy time or things like that. So there should be consistent in the environment. So that is one of the preventive measures. Some physical exercises, and then other alternative and complementary strategies like pet therapy and music therapy can be also included uh, uh, in the client care. And also socializations and leisure time activities, going for a walk, things like that. So these are all some of the preventive measures that can be taught to the abnormal patients. And then what are some multidisciplinary interventions like with the help of other therapists? We nurses also play an important role uh, in the psychiatric healthcare setup. So timely and rapid de-escalation. So that means you should have a if the person becomes suddenly violent, you should have some protocols pre-ready and protocols or teams ready to de-escalate rapidly to deal with that situation. So we should be ready. Nurses should make it. All the protocols should be known to all the person who is working in the psychiatric setting. So they should have a protocols, determined protocols and the steps to be taken when suddenly something happens. So then next is providing the client with clear and concise ways of to seize the behavior. And we cannot, when the person is having abnormal, suddenly violent behavior, we cannot. You should calmly make him to silent down. It should be clear and concise when the person is showing abnormal behavior. So when the person is also showing violent behavior, we should maintain eye contact at the same patient level and then calm him down. And then positive reinforcement is very, very important. Positive reinforcement is again in the behavioral therapy, which is being taught that positive reinforcement makes the person to change the behavior. So when the person tries to control himself, control his violent behavior, you have to say, good, very good that you could be able to control your anger or something like that. So we have to encourage the person when the person is showing the controlling his behaviors. Engaging the client in some form of physical activities like walking or some kind of dances and things like that. These are all some of the that things that happens in a psychiatric setup where the psychiatric nurses assist. And then next one is medication. Medication again when the person is really violent and not able to we cannot able to restrain him, then medications are used. And the last resort is restraints. Again, some of the things are like repetition, so we'll go fast. Assisting the client in using behavioral strategies to decrease the anxiety. So some of the like anxiety again, how to some of the behavioral strategies, how we can help the uh, uh, person to decrease the anxiety. First one is cognitive reframing. Cognitive reframing again. Cognitive reframing is again like it is a cognitive therapy. Actually, all these wrong conceptions, wrong presumptions of the person to be changed. All the negative thoughts are changed into positive thoughts. Like teaching him how to change these negative thoughts, like I am good for nothing, I am useless, things like that. So this is all wrong assumptions that person makes, and because of that he becomes depressed. And because of that depressed he can go for a suicidal attack. So changing those negative thoughts, changing those negative thoughts into positive, teaching him how to reframe it. No, I am good, everybody, my parents love me, so I am so and so, I have got such and such a talents, I am everybody needs me, things like that. So changing those negative thoughts into positive thoughts, that is called as cognitive reframing. So teaching those type of uh, um, cognitive therapy that happens basically in a cognitive therapies. So teaching, that is cognitive reframing. Deep breathing exercises, again deep breathing exercises is mainly diaphragmatic breathing. So holding the, taking a deep breath and releasing the, when you are releasing the deep the breath out, exhaling, you are exhaling also all your negative feelings. So that is called as deep breathing exercises. So teaching the deep breathing exercises to the patients. Progressive muscle relaxation techniques like contraction and relaxations of the muscles. So when we are contracting and relaxing, when these type of things are done, like contracting and progressively, for example, starting from the upper body to the lower body. So when you are contracting and releasing, what happens basically? Endorphins are released. So endorphins basically is a which calms down the, it gives a relaxation to the muscles. So that's how the anxiety is released. So progressive relaxation techniques. Then meditations, okay. Then prayer, like encouraging the person to pray. The prayer also gives the person a inner strength to deal with the anxiety. Next one is reminiscence therapy. So this is basically sharing the life story and memories and biographies and things like that, like showing the photographs and telling them to like um, uh, expressing what is that and things like that. So when the person shares the life story, then the anxiety level decreases. That is called reminiscence therapy. Then is validation therapy. Validation therapy is basically used. This reminiscence therapy is used for memory loss and things like that, so that the memory comes back, like showing the old photographs and things like that, books or something, and then making them to go back to their old days and tell what has happened. Things that is called as reminiscence therapy. And validation therapy again, it is basically used for dementia and things, that type of patients where you validate what all the person is allowed to express, and then you listen. Basically it is listening to the patient's story, listening to, and then making verbal cues like go ahead, then it must be very difficult, things like that. So when the nurses start listening to the patient's stories and things like that and acknowledge, then that eases the patients. So that is called as validation therapy. Then journaling, encouraging the persons to journal, write down what has happened today, what has happened, what is your feelings and thoughts that is coming in your journaling. It also helps so many, even the us also. Journaling helps a lot. This is guided imagery, going into the some thinking about a beach, walking in a beach and things like that. So that is got a guided imagery. And music therapies. Then is biofeedback. Biofeedback is uh, mainly a machine, electrodes are attached to the thing, and then when the person does that, the how heart rates and things like that are assessed. So that is biofeedback. And then mindfulness. Sorry. And then next one is setting priorities. Very important for psychiatric, like in a psychiatric healthcare setup, in a ward or something, giving them task and you have to supposed to do the priority and prioritize the task which is given to the psychiatric patients. And then positive self-talk. Self-talks and like self-talks for a schizophrenia patient, we cannot encourage it. This is from behavioral problems. For behavioral problems, we can encourage positive self-talk. And then medications. And next one is that is about the some of the things called anxious patients. And this is next one is orienting the client with reality, making the person to come back to the reality. So that is very, very important. For that purpose, we can use like promoting the client's cognizance for the personal identity, time, and environment that is surrounding. Like we can use an alarm or a clock in the room or some calendar to be kept in, making the person to orient himself to the time, place, and the person. Though, so that the orientation level of the person increases. For that, the nurses can encourage the person to see the calendar, add the dates, and then today what is the day and what did you do yesterday and what like things like that. So date, time, and month and years and such on, or like putting a TV channel and showing them the weather and things like where are you, which country you are, things like that. So that increases the reality perception of the psychiatric persons. So this is also like one of the role of a psychiatric nurse in helping in bringing the person to reality perception. So at the end, the core qualities of a psychiatric nurse is trust, empathy, respect, authenticity, seeking clarity, and active listening. These are all some of the like earlier interventions which I have explained, which I like in the other slides which we have seen. These are all like and a stigma and things like that. So these are all things that we discussed. The same thing is repeating. So these are all the summarization of some of the qualities that a psychiatric nurse should have. They should have a trust. They should have empathy. Trust is basically when you have a therapeutic relationship, respecting, listening, when you do eye contact, and when you introduce yourself, and you have some professional boundaries among yourself, so that the patient start developing a trusting relationship with you. So that is trust. Having empathy, active listening. Again, listening is very, very important for a psychiatric nurse. Listening to the problems, going into the shoe of the person. Like that is the meaning of empathy. So not just sympathy or pitying the psychiatric person or abnormally ill person, but also having an empathy towards the person. Respecting, not calling as a psycho, schizo, mood disorder, manic, and things like that, depressive or things like that, without labeling him, respecting the person is very, very important. Showing the authenticity. Yes, you are genuine in your care. The psychiatric nurse should show herself as that she is genuine in giving care to the person. Seeking clarity. If you are not able to understand what it is, you are going to clarify what it is. So clarifying between the patient and the nurse is very, very important. And then again, active listening is very, very, these are all some of the core qualities of a psychiatric. So in conclusion, we have got nurses have responsibilities to patient, families, and themselves. So we have to be very skillful and in identifying the behavioral changes of the psychiatric persons, and then we have to timely take the actions and things like that. So, and also we should avoid developing the stigma towards the abnormal behaviors and psychiatric in our nursing psychiatric nursing practices. We should always avoid stigma and and also having the improve our psychiatry by having when we have all these core qualities, we also improve our therapeutic relationship with the psychiatric persons. Thank you.
As well as the qualities which a nurse should have. Now there are two queries from the participant side. One is,
I'm not able to hear.
Ma'am, am I audible now?
Hello? Hello?
Audible?
No, I'm not actually. I cannot hear.
Ma'am, there are few queries.
Yeah, please.
How long time will it take to change the maladaptive behavior of the client? They want to ask how long will it take the therapies to have an effect on the client?
It depends on the every individual patients. We cannot say there is a specific time that we can change. There is a type of specific hopefully within this 1 month you can change your maladaptive behavior. It cannot be like that because every individual is different. Every mental illness is different. Every abnormality is different. So it depends on every psychological issues are different. As we saw on all the models, every individual's problems are different, so it cannot be like cannot have a specific time frame for changing the maladaptive behavior.
And the next question is how the biofeedback is helpful in abnormal behavior.
That is biofeedback I explained for an anxiety thing, when it is used as a therapy, where one of the way of a therapy which cannot be generalized that it is used for all the behavioral problems. It is for decreasing the anxiety level where the electrodes and the feedback is given. So see, your heart rate is increasing. So things like that. So it cannot be used for all the maladaptive. It is I explained for that anxiety persons.
The rest of the feedback is nice session and very informative. Thank you, ma'am. It was really a very good experience to have you on our conference. Once again, thank you, ma'am.
Thank you.
Now, as we end with our session, we would further proceed with the research presentation. So, knowledge is power and shared knowledge is power multiplied. With this beautiful quote, I invite one of our faculty members, Mr. Anmol Joseph, Assistant Lecturer, Choitram College of Nursing, Mental Health Nursing Department, for presenting his master's degree research. Over to you, Mr. Anmol.
Myself, Anmol Joseph, Assistant Lecturer, Choitram College of Nursing, is here to present my pilot study on effect of motivational enhancement therapy (MET) in association with self-controlled Android application on the level of internet addiction among nursing college students. Background of the study: the term internet addiction is been used synonymous with digital addiction, cyber addiction, net addiction, online addiction, pathologic internet use, cyber disorder, problematic internet use, techno disorder. Internet addiction is defined as when a person has a compulsive need to spend a great deal of time on the internet to the point where the other areas of life, such as relationship, work, or health, are allowed to suffer. The persons become dependent on using the internet and needs to spend more and more time online to achieve the same high. The internet addiction is not just a problematic habit, but as an emerging psychiatric illness, which is now recognized by all psychiatrists and psychologists around the world. Recently, DSM-5 edition has recognized Internet Gaming Disorder (IGD) as a mental disorder. Need of the study. Currently, India's population as per census 2018 is nearly 1.35 billion, out of which 566 million are internet users, which is nearly half of the population of India being currently using internet. According to UN report 2014, India has the world's largest youth population with 356 million Indians 10 to 24 years old, which puts the youth to be at greater risk for internet addiction and hamper the productivity of nation. Internet addiction also precipitates some psychological issues such as anxiety and depression and other behavior problems, which is the main concern. Increased violence, aggression, and suicide were found to be associated with the use of internet. Also, impulsivity was found to be higher in students and other psychopathology with internet addiction. Excessive use of internet also leads to many physical problems such as headache, feeling of stiffness, backache, neck pain, and insomnia. Statement of the problem. A quasi-experimental study study to assess the effectiveness of motivational enhancement therapy MET in association with self-controlled Android application on the level of internet addiction among nursing college students of the Indore in the year 2018-19. Objectives to assess the level of internet addiction among college students by using Young's internet addiction test in each groups, that is 1, 2, and 3, to find out association between level of internet addiction and selected socio-demographic variables in each groups, to measure the effectiveness of motivation enhancement therapy on the level of internet addiction among group 1, to measure the effectiveness of self-controlled Android application on the level of internet addiction among group 2, to measure the effectiveness of motivation enhancement therapy MET in combination with self-controlled Android application on the level of internet addiction among group 3rd, to compare the mean difference of the level of internet addiction after intervention among all 3 groups. Hypothesis. All the hypotheses were tested at a level of p less than equal to 0.05. First H1 was there was significant association between the level of internet addiction with selected socio-demographic variables. Hypothesis 2. There is significant reduction in the level of internet addiction among the group 1 students receiving motivational enhancement therapy. Hypothesis 3. There is a significant reduction in the level of internet addiction among the group 2 students receiving self-controlled Android application. H4, there is significant reduction in the level of internet addiction among group 3 students receiving motivational enhancement therapy in combination with self-controlled Android application. Review of literature was a study was conducted by Anand Nitin, Jen Praveen, A. Prabhu Santosh. A study title of the study was cross-sectional study to assess the internet use pattern, internet addiction, and cyber distress. It was done on the 1083 engineering students, and intervention as was used was socio-educational and internet use behavior. Data sheet was used to get a demographic information and patterns of internet use, and internet addiction test was used. The result was found that the result revealed 27.1% of students lie in the mild addictive internet addiction, 9.7% for moderate, and 0.4% in severe. Another study was conducted by Podar Subravarta, Syed Neha, and Mitra Srivastava in 2015. It was a case study report on internet gaming disorder and application of motivational enhancement therapy principles in treatment. The sample was 14-year-old adolescent. Intervention was MET, cognitive behavior therapy in a combined to treat internet gaming disorder, that is IGD. The result was problematic symptoms reduced significantly with significant cutoff internet time. Internet addiction test score came down. The study concludes on interesting application of tested MET with combined CBT principles in reducing IGD. Methodology, research approach, quantitative research approach. Research design was quasi-experimental, pre-test, poster design without control group. Population was all nursing college students aged 19 to 24 years. Target population was nursing college students of Indore. Setting was Kanya Coops College of Nursing in Indore. Sampling technique was simple random sampling. Sample size was 6 samples as it was my pilot study. Variables were independent variables were motivational enhancement therapy, Android application, and motivational enhancement therapy, and motivational enhancement therapy with Android application. Dependent variables were internet addiction. This was the research design. It was a pre-test, post-test design without control group. Sample selection criteria. Inclusion criteria for nursing college students of age 19 to 24 years of both gender. Nursing students who fell under the category of mild, moderate, and severe addiction after Young's Internet Addiction Test. Nursing college students who possess smartphones. Nursing college students who are willing to participate in the study. Exclusion criteria was students with other addictive behaviors. Students who have smartphones operating software other than Android. Students who fell under normal range after Young's Internet Addiction Test. Development description of tool. Section A comprises of socio-demographic variables which contain 19 items. Section A.2 contains self-report questionnaires for smartphone users, contains 8 items. Section B contains Young's Internet Addiction Test, contains 20 items. Likert scale. Tools was validated by experts. Tool linguistic translation was done by professional translators. Reliability of Internet Addiction Test. A cross-sectional study conducted in Bangalore, India among 1086 engineering students in the year 2019 revealed internal consistency that is Cronbach alpha to be 0.88 and test retest reliability was found to be 0.82, indicating a good internal consistency. Session for the therapy. Approval from Research and Ethical Committee of Choitram Hospital Research Center was obtained. Consent was taken from the participant detailing about the study. A pretest was conducted using Young's Internet Addiction Test among all available participants which fulfilled the inclusion criteria. All relevant samples, mild, moderate, and severe, were segregated into 3 groups using lottery method. All the 3 groups received distinct intervention in divided session. Group 1 received MET, Group 2 received Android application, and Group 3 received MET with Android application. For motivational enhancement therapy, the therapy was administered for 10 days divided in 4 sessions, each lasting for 1 hour. Trust and rapport was built and briefing was done about the therapy. Detailed interpretation and scoring of the Young Internet Addiction Test was explained to each individual participants. A brief PPT presentation along with some educative videos were shown to the participants. Change plan worksheet was administered to all participants. Techniques of MET such as presenting personal feedbacks, eliciting self-motivational statement, listening with empathy, questioning, simple reflection, reframing, discussing a plan, communicating free choice, and summarizing were utilized. Post-test was conducted after the end of entire therapy. For Android application, Android-based application named App Detox was downloaded from Google Play Store in individual participants' mobile for 10 days, divided in 4 sessions. Depending on the problematic application overused by the participants such as WhatsApp, Facebook, Instagram, TikTok, and PUBG, etc., restriction was set according to time usage per day. Initially, single application which was most overused by the participants was restricted. Restriction was based on the usage time. Minimum usage time was set for all the respective applications per day, after which the app detox will close the respective application if the usage time exceeds the time limit. Password was set on the app detox, which was only known to the investigator to prevent any tampering in the application setting. The restriction time was increased gradually and multiple application was restricted according to the comfort of the participants throughout the therapy. In case of emergency, participants were given liberty to uninstall app detox, which will restore normal functioning of the restricted application. Participants who uninstalled the application were excluded from the study. Post-test was conducted at the end of the entire therapy. And for the motivation enhancement therapy combined with Android application, the therapy was administered for 10 days, divided in 4 sessions, each lasting for 1 hour. Participants were sensitized with motivation enhancement therapy and Android application in combined way was an app detox was installed in each participant's mobile. At the end of the therapy, post-test was conducted. The results revealed the assessment of pre and post-test score of MET group. The total sample were 2. For the first sample, pre-test score was 68, which reduced to 48, and sample 2, the pre-test score was 49, which reduced to 31. It was for the MET group. And for the pre and post-test score for the Android group, the sample 1 pre-test score was 55, which slightly increased to 62, and the sample 2 pre-test score was 38, which slightly decreased to 35. And in the pre and post-test score of MET in combination with Android application, the sample 1 pre-test score was 83, which reduced to 65, and in sample 2, the pre-test score was 40, which reduced to 33. The paired t-test for pre and post-test scores for the internet addiction among group receiving MET showed that the mean difference was found to be 19, SD was 4.922, standard error came out to be 3.490, and t-value came out to be 26.95. The table depicts that there was a significant reduction in the level of internet addiction in pre-test and post-test after intervention at the level of p less than equal to 0.05, and research hypothesis H2 was accepted. In the T table, T-test of pre and post test score of level of internet addiction among group receiving Android application, the mean difference was -2, SD was 5.09, standard error was 3.60. The T value came out to be 0.4, which was non-significant. The table depicted there was no significant reduction in the internet level of internet addiction in pre and post test after intervention at the level of P less than or equal to 0.05. Hence, research hypothesis S3 was rejected. In the t-test of pre and post-test score of level of pre-test score of level of internet addiction among group receiving MET with Android application, the mean difference came out to be 12.5. SD was 7.778, standard error 5.500, and the T value came out to be 2.27, which was not significant. The table depicted there was no significant reduction in the level of internet addiction in the pre-test and post-test after the intervention at the level of P less than or equal to 0.05. Hence, research hypothesis H44 was rejected. Conclusion: the study emphasized among all three approaches, MET was found to be effective and statistically significant in reduction of internet addiction. Although MET with Android application also showed effectiveness and was not found statistically significant, and Android application failed to create impact on level of internet addiction. Hence, intrinsic motivation was the key factor in reducing internet addiction. Take home message: I finally realized people are the prisoners of their phones. That's why they are called cell phones. And before you can break out of the prison, you must realize you are locked up. Thank you.
So next, I invite our next faculty, Mrs. Christy Abish, for her research presentation. Over to you, Christy, ma'am.
Myself, Christy Abish, Assistant Lecturer, Choitram College of Nursing, here to present my research study. Title of the study: Effect of Coping Skill Training in Reducing Examination Stress Among School Students. Background: students are subjected to different kinds of stressors, such as the pressure of academics with an obligation to succeed. Moreover, the transition between the middle childhood and adolescence represents a confluence of social, academic, cognitive, physiological, and physical changes. Stress can be defined as any factor that threatens the health of a body and has an adverse effect on its functioning. Coping is the process of managing demands that arise as taxing or exceeding the resources of the person. Coping is a set of responses occurring over time by which the environment and the person influence each other. Coping skill training involving learning instead to relax using progressive muscle relaxation so that whenever or wherever you are experiencing stress, you can let go of the tension. Next is the need of the study. Everyone has stress and we face it in our daily life. Students face more stress compared to the others. Stress brings advantages as well as disadvantages to us. It depends upon how students look upon and take over them. Stresses can cause distress and emotionally affected, while on the other hand, stress gives us motivation to achieve further success. Stress related to examination is common in students, which leads to negative outcomes. One cannot completely eliminate stress from one's life, but can control how much it affects. One may feel like the stress in life is out of control the way one responds. Keeping this in view, in mind, the topic of the study is selected for the research. Statement of the problem: a pre-experimental study to assess the effectiveness of coping skill training on examination stress among school students at selected schools of Indore in the year 2015-16. Objectives of my study: to assess the level of examination stress among school students, to assess the level of coping strategies among school students, to explore the level of perceived social support among school students, to find out the association between the level of examination stress and selected demographic variables, and to evaluate the effectiveness of coping skill training on examination stress among school students. Hypothesis H1: there is a significant association between level of examination stress and selected demographic variables at the level p less than equal to 0.05. H2: there is a significant difference in the level of examination stress among after coping skill training among school students at the level p less than or equal to 0.05. Research methodology: pre-experimental research design, pre-test intervention, and post-test. Pre-test socio-demographic assessment, test anxiety inventory, simplified coping style questionnaire, multidimensional scale of perceived social support. These are the tools used for the study, and I have implemented coping skill training as the intervention, and posters in posters I have tested test anxiety inventory, simplified coping style, and questionnaire. Then target research design: target population high school students, accessible population is students studying 10th class, meeting the inclusion criteria. Background factors are age, gender, class, source, parents, education and occupation, family income, socioeconomic status. And sampling technique is purposive sampling, and the sample size was 30 students. Pretest was done, intervention was provided. It consists of 10 sessions, and the posters was conducted. Analysis and interpretation was conducted. Through descriptive and inferential statistics, findings were found, and reporting the thesis. This was a schematic representation of my research study. Sample selection criteria: inclusion criteria, students who scored 41 to 50 marks, that is moderate level of anxiety, and 51 to 80, that is high level of anxiety, as measured by test anxiety inventory. Students who are willing to participate in coping skill training, students studying 10th standard, students who are available during the data collection. And exclusion criteria was students those who had previous exposure to coping skill training, and students with psychiatric or neurological disorders. Recruitment chart: enrollment was N is equal to 32, students of 10th standard. Screening was done by test anxiety inventory, and the students with high and moderate test anxiety were selected, and excluded 2 students with low test anxiety. Purposive allocation was done. Pretest was conducted for N30 students, and coping skill training was done, and no dropouts was there, and posters was conducted for the same 30 students, and analyzed students were 30. And development and description of the tool: session A, socio-demographic tools, which contains 14 items, and session B, personal variables, which contains 6 items. Session C, Spielberger test anxiety inventory, consists of 20 items. Session D, size simplified coping skill questionnaire, contains 20 items. And session E, SIMMETS multi-dimensional scale of perceived social support, which contains 12 items. Procedure for data collection: main study was conducted from 7 June till 9th July 2016 at FGM Higher Secondary School, Devas. Written permission from the concerned authority was taken, and 30 students of 10th standard were selected who fulfilled the inclusion criteria. Study purpose was explained to them by means of informed consent with assurance of confidentiality. A total of 10 sessions was conducted. Each session lasted for 45 minutes in morning 11 to 11:45 a.m. and follow-up also was done on 8th August 2016. Sessions of for coping skill training was: day 1, introductory session was conducted for an hour with the students. The students were explained about the coping skill training, informed consent was taken, students were oriented with the details of the session, students were explained about the intervention source, beginning with the Benson relaxation technique, and started the sessions. And day 2, step 1, screening of the students were done by test anxiety inventory, pre-test assessment of simplified coping style questionnaire, multi-dimensional scale of perceived social support. And day 3 and day 4, preparation and confronting the stressful situation. Students were asked to write down the problems they were facing. The problems were pressure of the board exam, worried about failing, memory problem, tension about career, change of examination center, describe about the brain and process of learning. And day 5 and 6, discuss about the types of memory, explore the good study habits, discuss about the bad study habits. Discuss about the bad study habits in the day 7. Select a day 7 may discuss about good study habits. Select a time and place to study. Read and understand for 30 to 45 minutes. Write down a summary for important points and relax for 3 minutes. And day 8, how to get rid of examination stress. Do not worry about the past failure. Study from the beginning. Do not strain yourself. Take care of your body with adequate food, sleep, and relaxation. Do breathing exercise twice or thrice a day. And day 9 and 10, reinforcing success, beds and relaxation technique was practiced, and problems of students were discussed. Help the students to reduce their problems. Videos on how to manage examination stress and post-test was conducted, and followed by that 1 month follow-up was also conducted. Frequency and percent distribution of pre-test level of test anxiety and was 30, and test anxiety grading. Low score was 20 to 40. No one acquired low score. Moderate 21 students acquired moderate score, and high 9 students was in a high test anxiety. And frequency and percentage distribution of pretest level coping strategies. 29 students had moderate coping method, and 1 student had a high coping method. And frequency and percentage distribution of pretest level of perceived social support. No one had low perceived social support. Moderate 9 students had moderate social support, and 21 students had high perceived social support. Association between level of test anxiety and selected socio-demographic variable chi-square was done. No significant association was found between the level of examination stress and selected demographic variables such as family type, number of siblings, ordinary position in the family, scholastic performance, father's education, father's occupation, mother's occupation, symptoms, coping, hobbies, and time spent on hobbies at the level P less than or equal to 0.05. There is a significant association between the level of examination stress and selected demographic variables such as age, gender, socioeconomic status, exam fear, and profession. Hence, the research hypothesis H1 is accepted for selected demographic variables such as age, gender, socioeconomic status, exam fear, and profession. Effectiveness of coping skill, training on examination stress, paired t-test was done, and pre-test mean score was 46.2. Post-test mean score was 33.9, mean difference was 12.3, ST of pre-test was 5.48, and ST of post-test was 5.24, and SC was 1.38, DF was 29, and the T value was 8.88. That was a significant value, and the table value was 2.05. Next, post-test and follow. Post-test mean difference of mean of post-test was 33.9, and for mean of 1 month follow was 30.5. Mean difference was 3.4. ST of post-test was 5.24. ST of 1 month follow was 4.30. SC 1.23. Difference. DF was 29 and P value was 2.76 and table value was 2.05. H2, there is a significant difference in the level of examination stress after coping skill training among school students at the level P less than or equal to 0.05. Thus, the research hypothesis H2 was accepted. An evaluation of unit test score. I have conducted a unit again 1 month follow-up in that in unit test evaluation. In first unit test, majority 14 students acquired 61 to 80%, and 7 students scored 81% above, and 6 scored 41 to 60%, and 3 scored below 40%. On the contrary, after the intervention in second unit test, majority 70 students scored 61 to 80%, 10 scored 81% above, and 3 scored 41 to 60, and no one scored 40%. This was the performance of the students. And conclusion, school students often tend to seek alternative ways to manage their anxiety, examination stress, physical and mental health problems, self-help treatments such as coping skill training, relaxation, counseling seem to offer desirable physical and mental benefits. Take home message, two words will help you cope when you run on hope, accept and trust. Charles, these were the references. Thank you.
Feeling gratitude and not expressing it is like wrapping a bill and not giving it. So I would like to invite Associate Professor Anthony Gosina for delivering both of time. Over to you, Anthony. Thank you, Sharanya. Good afternoon to everyone. The essence of all beautiful art is gratitude. Here we come to an end of the 2 days international conference on mental health, concepts, and psychotherapy. I, Mrs. Nancy Murphy, on behalf of Chopra College of Nursing, its center fraternity, and the organizing committee, feel immense pleasure to take this opportunity to conclude the conference and propose a vote of thanks. My first and foremost thanksgiving goes to the Almighty God for making this conference a successful one. A big thanks to Choitra management, especially to Sri Satish Muntyali sir, trustee of Choitra Trust, and all other managing committee members for providing us this platform to conduct all academic activities during lockdown and for giving us the chance to organize the conference and availing all the physical facilities which are needed. Thank you, sir. Next, I would like to extend my thanks to Dr. Sunil Chandiwal, Director Medical Services, Choitram Hospital and Research Center, which is also the parent hospital of our college. Sir is very cooperative and helpful all the time, and with his coordination, we have successfully organized this conference. Thank you, sir. My heart fills with lots of gratitude and respect to our distinguished speakers for sparing their valuable time for us to grace this conference, but also for enlightening us with their commendable talks. Thanks all of you for clearing our concepts and enhancing our understanding returning to mental health concepts and psychodynamics. I would like to express my sincere thanks to Dr. Ashish Goyal, consultant psychiatrist, Choitram Hospital and Research Center, Indore, for giving a brief introduction on common mental disorders and management. Thank you, sir. I must mention our deep sense of appreciation to Dr. Deepthi Christian, former head Department of Psychology, Hislop College, Nagpur, for her explanation on conceptual models, that is existential model and behavioral model. Thank you, ma'am. I'm also very grateful to Dr. Priscilla Sampson, Principal, Pathan Academy of Health and Sciences, Kathmandu, Nepal, for explaining another set of conceptual models, that is psychoanalytical model and interpersonal model. Thank you. With these 3 sessions, we came to an end of the first day of conference. Today, the session started with Dr. Priya A. Rajkumar, Managing Director, Rainbow Management Consultancy, Nagpur. I wish to express my gratitude to you, ma'am, for giving an excellent coverage on the topic maladaptive behavior in the context of COVID-19. Thank you, ma'am. Further, we are grateful to Dr. Priyanka Mathuri, Assistant Professor, St. Luke's College, Agra, for explaining in detail on the topic cognitive behavior therapy. Thank you, ma'am. And finally, I would like to acknowledge our gratitude to our last speaker, Dr. Sulekha VK, Principal School of Nursing, New Memorial Hospital, Nagpur, for enlightening us with concepts of normal and abnormal behavior and role of nurse. Thank you, ma'am. Once again, I extend my sincere thanks to all the speakers. My heartfelt thanks to all the delegates for accepting our invitation organize